morning, everyone. I am Dr. Roshni. Today, we'll be discussing about chronic hepatitis. Okay, next topic. So, this is a very important topic. Previous class, I think acute hepatitis has been discussed in detail. So, this is the continuation of chronic hepatitis, acute hepatitis. So, chronic hepatitis, I'll give you a brief description, but the topic has been divided into two classes. Half of the topic today I will be discussing. Okay. So, chronic hepatitis. Chronic hepatitis represents a series of liver disorders of varying causes and severity, in which hepatic inflammation and necrosis continues for at least 6 months. Milder forms are non-progressive or only slowly progressive, while more severe forms may be associated with the scarring and architectural reorganization, which when advanced leads ultimately to cirrhosis. So the course of chronic hepatitis I will be discussing in the later slides. Okay. Several categories of chronic hepatitis have been recognized. These include chronic viral hepatitis, drug-induced chronic hepatitis, and autoimmune chronic hepatitis. So in this, today I will be discussing about, for you, the important topics. Everything is important. Most important is chronic viral hepatitis and autoimmune chronic hepatitis. And I will be discussing about chronic viral hepatitis, and that too mainly hepatitis B and D. Okay. So the rest, the C, E, and autoimmune chronic hepatitis will be discussed in the later class. Okay. So what is the classification of chronic hepatitis? I'm just briefly talking about the chronic hepatitis introduction. We'll be going into the details of the viral hepatitis. Okay. Classification of chronic hepatitis, it is classified. This is the older classification and this is the newer classification. So this is followed now, newer one. Older one was based on the prognostic implication. And now it is divided into chronic persistent hepatitis, chronic lobular hepatitis, and chronic active hepatitis. The chronic persistent and the chronic lobular hepatitis are the milder forms. Okay, and chronic active hepatitis is the severe form. This is the previous classification which was determined to follow. Okay, so the newer classification is categorization of chronic hepatitis is based primarily on the histopathologic features that has been replaced by a more informative classification based on a combination of, so only based on histopathologics, like this is persistent, lobular, and active. This was only based on histopathology, but it was not enough. Okay, so clinical, serological, as well as histological variables are also important. So based on that, the classification of chronic hepatitis, that is newer classification, is based on its cause, its histologic activity or grade, its degree of progression based on level of fibrosis or the stage. Okay. So what is the etiology of chronic hepatitis? Okay. First being the viral, as I told you, chronic viral hepatitis, viral, both acute and chronic. So viral, what is it causes are hepatitis B, hepatitis C, and hepatitis D mainly. Okay. There is also A and E. Okay. So chronic hepatitis causes are B, C, and D. Acute is caused by A, E, B, C, and D also. Okay. Drugs like alpha-methyl dopa and isoniazid. So this is the drug-induced hepatitis. Alcoholic liver disease, non-alcoholic steatohepatitis, and metabolic causes like primary biliary cirrhosis, sclerosing cholangitis, alpha-1 antitrypsin deficiency, Wilson's disease, hemochromatosis. The next one is autoimmune hepatitis. Okay, these are divided into type 1, type 2, and type 3. then cryptogenic cause. Okay. Okay, so this is the brief description of the chronic hepatitis. So I'll be going, and today I'll be, as I told you, I'll be discussing about the viral hepatitis, that is chronic viral hepatitis. So first one I'll be discussing about is chronic hepatitis B. So this is an important topic for you, both now theoretically as well as practically in this Viva wise, as well as clinically in your future. Okay, this follows us like a leech. Okay, so just remember the important points. Okay, so chronic hepatitis B, entire clinico-pathological spectrum of chronic hepatitis occurs in patients with chronic viral hepatitis B and C, as well as in patients with chronic hepatitis D that is superimposed on chronic hepatitis B. So this is the reason why I am discussing the D along with B, because the chronic hepatitis D is always associated, or it requires chronic hepatitis B to occur in a human being. So this is the second point is important, that is when infection occurs at birth, it is associated with clinically silent acute infection, okay? And there is a 90% chance of chronic infection. Those infection, chronic hepatitis B, which has occurred at birth, has a 90% chance of chronic infection. Whereas infection in young adulthood, that is, it should be immunocompetent persons. Where when acute hepatitis occurs, the risk of chronicity is 1%. So remember, when the chronic acute hepatitis affects at birth, there is 90% chance of chronicity. And when it affects in young adulthood, the risk of chronicity is 1%. This is a frequently asked question in PG bits also. Okay? The degree of liver injury, that is the grade as per classification in patients with chronic hepatitis B, is a variable ranging from none in inactive carriers to mild, moderate to severe. Okay? Among adults with chronic hepatitis B, the histologic features are of prognostic importance. So, prognosis-wise, histologic features are important. So, chronic hepatitis B is caused by hepatitis B virus. So, let's discuss. It must have been discussed initially in acute hepatitis. So, this will be definitely a brushing up. Okay, I hope you have read the previous classes. Okay, so hepatitis B virus is a DNA virus that belongs to Hepatinidae virus family. Okay, 8 genotypes of this hepatitis B virus have been identified, and these are labeled as from A to H. Okay, the hepatitis B virus consists of a core surrounded by a surface protein. The virus and an excess of its surface protein known as hepatitis B surface antigen, HBsAg. Remember, these antigens and antibodies and the serological markers is very important. I have created 2 to 3 slides repeatedly so that will be, even though you're not listening, it will get into your head silently. So kindly, please pay your concentration on this. Okay, this is very important. 4 marks question, essay, as well as in PG bits. This is a very important question. Okay, it will be confusing. So kindly read it twice or thrice. Okay. So I'll be discussing about the structure of virus. So you'll have a picture of it. Okay, an idea. So humans are the only source of infection. Hepatitis B infection affects 300 million people, and it is one of the most common causes of chronic liver disease and hepatocellular carcinoma worldwide. Okay, this is the course of the liver disease. Hepatitis B virus with or without cirrhosis causes 60 to 80% of HCC worldwide, that is hepatic cell carcinoma. So this is important. Either cirrhosis is the midway. Okay, so cirrhosis might be there or might not be there. 60 to 80% of hepatitis B virus results in hepatic cell carcinoma. Okay. So the hepatitis B virus related mortality is estimated between 5 lakh and 1 lakh deaths worldwide per year. Okay. Hepatitis B virus is an indication for 15 to 10% cases for the liver transplant. So these are the major points. Okay. So 60 to 80% causes hepatocellular carcinoma. 15 to 10% cases are for the liver transplantation. So this slide shows the structure of the hepatitis B virus. Okay. So this is most important in acute as well as chronic. Today I will be discussing both, that is brushing you the knowledge of acute and going into the details of the chronic. Okay. So this is the small DNA virus with unusual features similar to that of the retrovirus. Okay. So this is the prototype, as I told you before. This is the prototype virus of the Hepatinidae family. So there are 6 viral particles in this Hepatinidae family that is related to hepatitis B virus. 2 of these viral particles are smaller spherical structures with a diameter of 22 nanometers, and the spheres and filaments are composed of the, as I told you before, hepatitis B surface antigen. So this, as you see, this is this surface. Okay, here it is hepatitis B surface antigen. And so now I am talking about that out of 6, the 2 viral particles which are non-infectious. Okay, the structure is same for all the 6. Okay, so the specificity in these 2 viral particles is that this has a hepatitis, that is HBs surface antigen, and host-derived lipids without nucleic acids. Okay, so that is why they are non-infectious. Okay, hope you understood. Out of 6, these 2 viral particles do not have the viral nucleic acids. Only the HBs antigen and the host-derived lipids are there. So they are non-infectious. Now let's talk about the infectious HBV virion, that is known as Bain particle, B-A-N-E, Bain. Okay, so hepatitis B virus is also known as a Bain disease. Okay, the infectious HBV virion Bain particle has a spherical double-shelled structure which is 42 nanometers in diameter, consisting of lipid envelope containing the hepatitis B surface antigen that surrounds an inner nucleocapsid. This is the nucleocapsid composed of hepatitis B core antigen. Okay, complexed with virally encoded polymerase and the virally DNA genome. So this contains the virally encoded polymerase. This is the danger part. Okay, this is the main difference between the non-infectious and the infectious. You need not remember these details. I'm just explaining it to you for your understanding. Okay, you just remember the structure of an infectious HBV particle virion. Okay, okay. So the main paper, it has a spherical double-shell structure, 42 nanometers in diameter. The surface consists of the hepatitis B surface antigen, that is nothing but HBs antigen. Okay, inside there is a core. This core, in between the core and the surface is the envelope, that is the hepatitis B antigen. Okay, this envelope surrounds the nucleocapsid consisting of the HB core antigen complexed with the virally encoded polymerase and viral DNA genome. Okay, that is HBV DNA. So these are the main important points. Serological and virologically, we need this HBs antigen, HBE antigen, HBC antigen, and HBV DNA and the respective antibodies. Okay, I'll be discussing it later. Hope it has gone into your head. Okay. So the genome of HBV is a partially double-stranded circular DNA. So inside it is a double-stranded circular DNA of about 3.2 kilobase pairs. Okay. So as I told you before, what is the clinical course of hepatitis B virus? Okay. What is the resultant when an acute hepatitis occurs or a chronic hepatitis occurs? Okay. So I have shown you it's diagrammatically as well as a flow chart, so that you will remember easily. So see, here you can see the diagram of a normal liver. Okay, when it is hit by hepatitis, that is acute, either in birth or acquired. This is acute hepatitis. This results in acute hepatitis. So what is the resultant of acute hepatitis? You remember from the previous class, huh? It is self-resolving mostly. Okay, 80 to 90% it is recovered, self-resolving. The rest of the 1%, so as I told you before, at birth, 90% has chronicity of 90%. And when it is acquired in young adults, that is immunocompetent adults, there is only 1% of chronicity. So we are talking about the 1% or the 90% of the birth. That results in chronic liver inflammation, or it is known as chronic hepatitis. Okay, can be due to causes. So this I am talking about. Let's take a picture of the hepatitis B itself. Okay, this chronic liver inflammation or chronic hepatitis later on leads into liver cirrhosis if the inflammation and the active replication continues in chronic hepatitis. Okay, and this cirrhosis ultimately results in hepatocellular carcinoma, which is the fatal end liver disease. Okay. So this is the diagrammatic representation. This flow chart, don't get confused, it is very simple. Just the main points, remember the diagrammatic representation has been picturized with percentages. Okay, this percentage is important for you and PG bits wise, and if you write it in theory, it will be scoring. Okay, so see, here when there is the patient or the person is affected by acute hepatitis B virus infection, it results in acute hepatitis, is it? So, how much percentage? More than 25% may result in acute hepatitis. Okay. So, acute hepatitis, as I told you before, the max amount of acute hepatitis is resolved or self-resolving or recovered, or slight infection may occur and then it is resolved. So, 99% is recovered. In between, as I told you, some may result in some small clinical infection, subclinical infection. In here, only more than 65%. So this ultimately results in recovery. So only 1% results in the death. I'm talking about the acute hepatitis. Now, coming to the later on stage, the 1 to 10%, as I told you, acute hepatitis B virus results in the chronic hepatitis. What happens? Chronic hepatitis, as I told you, 60 to 80% is non-progressive. Okay, and 20 to 40% is progressive. So what is the progressive, as I told you? See, the cirrhosis, the diagram. Cirrhosis, then hepatic cell carcinoma. Okay, so you compare this diagram and it's only percentage wise you remember, that's it, roughly. Okay, this is important and this percentage is also important. Okay. So what are the modes of transmission in hepatitis B virus? Okay, this is both acute and chronic I'm talking about. It applies to both. Okay, horizontal, there is horizontal transmission as well as the vertical transmission. What are the various routes of horizontal transmission? What do you mean by horizontal? Horizontal means transmitted like this. Vertical means like this, from mother to infant. Remember, like that. No confusion. Horizontal transmission is via parenteral or percutaneous routes, that is needle stick injury, injection drug use, hemodialysis, and via transfusions. Sexual contact, that is men who have sex with men, sexual promiscuity, or intercourse with HPV infected partners. So this is the diagrammatic representation I have put for you. Mode of transmission: non-sterile tattooing needles, via dialysis, via vaccination, any kind of vaccination like rabies or anything. So any non-sterile. Nowadays, you don't see, because everything they are using all disposable and very safe precautions. Initially, when there was an age where they used to use the glass bottles for IV fluids, okay, you must be seeing in the old films, okay, 80s and 90s films, for blood transfusion, they used to use the same glass bottle. Then this hepatitis B virus transmission was very common, okay. So this is the non-sterile dental practices, contaminated drug needles, IV drug users, and non-sterile body piercing equipment or tattooing equipment. Okay. I'll ask you an interesting question. I hope you all know. Who is the celebrity? He's a Bollywood celebrity who has been affected by hepatitis B. He's also having tuberculosis. You tell me in the next class, okay? So, now this slide is showing the natural history of chronic hepatitis B infection. What is it? Natural history means this slide, see, it shows that is chronic hepatitis B depends on 3 factors, as I told you, clinically, physiologically, and histopathologically. So that has been shown in this slide. So viral load, liver transaminases, that is, what is it? Alanine transaminase and aspartate transaminase. Okay, and liver histology. Based on this, the acute to chronicity or chronicity, how it goes on, okay, is shown in this slide. So initially, see, obviously the chronic infection has been affected. So from acute, here from acute infection, we have gone into the chronic infection. So chronic infection, when it affects, what happens to the viral load? Obviously the viral load is high. Okay, this diagram shows that high viral loads and you are having normal liver biochemistry. That is, liver enzymes are normal initially. Okay. Then an immunological response. The host does not remain silent. So the immunological response to the virus occurs, which results in elevation of the enzymes. Here is where the patient presents with, what is the clinical feature over here? Jaundice. Okay. Here is where the patient, and this elevation in serum transaminases causes the further liver damage, because already the host is in chronic hepatitis, not acute. So jaundice occurs and further liver damage occurs. Okay. So minimal inflammation. Are you understanding? Okay. So this is known as chronic hepatitis. If this response is sustained over many years, okay, and viral clearance does not occur promptly, that results in cirrhosis. Chronic hepatitis and ultimately cirrhosis. So this is the time period where, so the liver enzymes initially it increases, and then over the years where virus does not either clear or clearance has occurred, over time it will be, enzymes will be decreased. So depending on the enzymes, so that is why we are taking into account of all the features and classified the hepatitis. So based on only one feature we cannot. So if enzymes are normal, does it mean that patient is not having chronic hepatitis? No. Okay. So this results in cirrhosis. In individuals who mount to a successful immunological response, okay, so initially there will be an immunological response. Then if it is successful, okay, the host has a good immunity, then the viral load falls. Okay. Now when the viral, remember always, HB antigen positive. If the host shows the HB antigen positive, it indicates active viral replication. That is, virus is replicating in the host. Okay. So the patient is having active inflammation is going on over there. Remember that point. Okay. These bits are, I have categorized all the antigens and antibodies. If what is there, then what happens? I'll tell you at the end of the slide. So kindly note it down in your notes. You will only get it in PG bits and all. It's very important. If you have that in mind, this theory writing is also easy. Okay. So where was I? So when there is an active viral load, initially viral load, that is active replication, that is HB antigen positive. So over time, in the years when there is an active immunological response from the host and the viral load has decreased, then the HB antigen is negative. See, that period bottom, HB antigen is negative. Then what does it indicate? What does it indicate when antigen is negative? The body has developed the antibody. So what is anti-HBE antibody has developed? Okay. So it indicates there is no further liver damage. Why? Because there is no active replication. So always remember, HB antigen mane HBV, the HB virus replication. So there is damage. When HB antigen negative, it indicates there is no viral replication. Okay. Some individuals may subsequently. So this is the normal phase. Okay. HBV and the normal course or history of where hepatitis B virus leads to another phase. Okay, so this phase is hepatitis B virus tolerant, then HBV clearance, as I told you, and this over years where enzymes are also down and the viral load is also down. That is, the patient is having or the host is having active immunological response where there is antibody development. There it is known as latent phase and HB antigen negative. Okay, this is known as latent hepatitis. Okay, this is actually sometimes dangerous because they are carriers. Okay, so now a typical different situation is HBV mutant. Here, what happens subsequently develops this. This is that HBV virus is adamant, stubborn, that it won't clear from them. Okay, so there it escapes the overall immune regulation. That is, there won't be any response for immune body response. The viral load again rises with further chronic hepatitis. Okay, then the mutations in the core protein results in the virus inability to secrete HB antigen. So here what happens, this is a special part. As I told you, normally hepatitis B virus replication is that HB antigen will be produced. So because of the lack of or there is mutation in the core protein releases the HB antigen. Okay, there is mutation in the core protein. That's why HB antigen is not released despite of viral replication. So remember HBV mutant. Okay, so that's it. So this is the overall slide. I hope you have understood. Okay. So what are the clinical features presenting in chronic hepatitis B? It is broad, ranging from asymptomatic infection to debilitating disease or even end-stage fatal hepatic failure. So chronic hepatitis, initially you don't have any specific symptoms except for the fatigue. So in this, see, you can see, okay, when the liver enzymes rise after a few weeks or something, then you get the jaundice. So that is vague. Okay, fatigue and persistent or intermittent jaundice. Okay, whereas in debilitating disease or even end-stage fatal hepatic failure, there are so many symptoms, both important clinically and practically. Okay, when you go into practicals, it will be discussed, and it is very important. Okay, the spider maybe, the dupuytren's contracture. Okay, this is all portal hypertension. This is all important. And then this will be discussed in cirrhosis and hepatocellular carcinoma. Okay. Intermittent deepening of jaundice and recurrence of malaise and anorexia as well as worsening fatigue are reminiscent of acute hepatitis. Yeah, I have told you. Exacerbations may occur, often coinciding with virologic reactivation, may lead to progressive liver injury. Okay. So this slide shows the pictographic features of the clinical features of hepatitis B. Jaundice. Where do you see jaundice? That's the question for you. Where do you see icterus? It's known as icterus. Clinically, where do you see? What are the sites where you see? This is not only the site. Remember, okay? Next class you have to tell me. Then this is the pruritus and the flu-like symptoms like fatigue and fever. And the patient may present with abdominal pain, nausea, vomiting, and the pale color. This is the later stage. In cirrhosis and all patients present. Okay, pale or clay colored stools, dark urine. Okay. And this is the clinical side where you present the, where the physician clinically evaluates that there is hepatomegaly. Okay. Here the questions are, what are the methods of elicitation of hepatomegaly? What are the areas of the abdomen? Okay. And this is also they are showing the liver with hepatitis. There might be hepatomegaly. Okay. Complications of cirrhosis. So what are the complications in hepatitis B virus? Definitely the complications are of the later on stage, not the before stage. That is cirrhosis or the hepatocellular carcinoma. So that these are the complications I have told you. Ascites, edema, generalized edema, or the molybdenal edema might be there. Okay. Bleeding, sorry for this spelling mistake. Bleeding, esophageal varices, hepatic encephalopathy, coagulopathy, hypersplenism. So you also have to palpate for the spleen in the abdomen. What are the extrahepatic complications? Arthralgias and arthritis, purpuric cutaneous lesions. That is the reason for that is leukocytoclastic vasculitis. Okay? Immune complex glomerulonephritis, generalized vasculitis, that is nothing but PAN, polyarthritis nodosa. So, laboratory diagnosis, what all you have to see. Okay, as I have told, this is also discussed in before. Obviously, enzymes will be discussed. Then alkaline phosphatase. So, what all? Aminotransferase elevations tend to be modest for chronic hepatitis B. That is, it fluctuates. Okay, it doesn't be elevated as of always. Okay, 100 to 1000 units. And acute. So, this second point, remember. The enzymes, how it varies in both acute and cirrhosis, that is chronic. Acute viral hepatitis, the alanine aminotransferase is much elevated than the aspartate aminotransferase, whereas it is reverse in cirrhosis. Aspartate is more than the alanine aminotransferase. Okay, this is important. This is asked here, practical, viva, everything. Okay. And then what else you'll see? Alkaline phosphatase activity. It is normal actually or marginally elevated. In severe cases, then we see for the serum bilirubin, the itteric. Okay, 3 to 10 milligrams per deciliter. Then hypoalbuminemia, that is decrease in proteins, prolongation of prothrombin time. Why prothrombin time? Why there is prolongation of prothrombin time when the liver affects? Read and tell me. Okay. This occurs in severe or end-stage cases. And here also complications I have discussed about the coagulopathy. Why? Why does it occur? Okay, read and tell me. Hyperglobulinemia and detectable circulating autoantibodies are distinctly absent in chronic hepatitis B. That is, this is important. Hyperglobulinemia is an important feature of autoimmune hepatitis. Remember, autoimmune means these self antibodies we develop and then that complexes causes hepatitis. I'm not going into the detail. Like that you can remember. So hyperglobulinemia is a feature of autoimmune hepatitis and not much of hepatitis B. Okay, it doesn't much of them. So coming to the serology, in acute infection, hepatitis B S antigen is a reliable marker. So serology is important. I will be spending a little time over here. Please concentrate on what I'm saying. Okay. So I'll be explaining it with a diagram. Okay. That is very, 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 very important. Crucial. Okay. So what happens in acute infection? Hepatitis B antigen is a reliable marker. Okay. This appears after about 3 to 6 months versus for many years or even permanently. And then later on, what does anti-HBs indicate? It indicates either there is a previous infection in which anti-HBC is also present. And then whether there is a previous infection or previous vaccination, anti-HBs implies. Okay. The hepatitis B core antigen is not found in blood, but antibody to it is found. So you don't see for hepatitis B core antigen in the blood. Okay. So what does anti-HBC indicate? It appears early in the illness. Okay. It is either of IgM type or IgG antibody. So initially IgM, then later on IgM is cleared and IgG anti-HBC core antigen is released. Hepatitis B antigen is an indicator of active viral replication, as I have told you 100 times. It appears transiently at the outset. This I have discussed already in the graph. Chronic hepatitis B infection is marked by the persistence. So what this I will tell you later on. I have made a detailed note, so you have to know. So this graph I am telling you, this has already been discussed in the acute hepatitis in previous class. So I am just brushing it up. Okay, just brushing it up. So this graph, what does it show? This is the markers which appears in the various regions of the various times of the illness, and these are the weeks, time after exposure, 1, 2, 3, 4 weeks. Okay, in between weeks, and these are the months. Okay. So remember this color coding, and this graph, if you draw it in theory exam, it is very scoring. When this question is given, this graph is compulsory in the paper. Okay. So what happens initially in acute hepatitis B? What is the course of these markers? Okay. So initially HBV DNA is released. There is already there. Okay. So it is followed by hepatitis B S antigen and hepatitis B E antigen. So these two are released. So you can see the blue one is hepatitis surface antigen and hepatitis B. What is this? E antigen, envelope antigen. So HBV DNA is already present, followed by these two. These are the first viral markers detected in serum. So when you go for the test, these are the first viral markers detected. Okay. Then HBs antigen may be detected as early as 1 to 2 weeks or late as 11 to 12 weeks after exposure. See, 11 to 12 weeks, that is 3 to 4 months. Okay. And its persistence, if it is persistent throughout, what does it indicate? It is a marker of chronicity. Hepatitis B S antigen is a marker. If it is persistent, it is a marker of chronicity. What is HBe antigen? Correlates with high levels of HBV replication and infectivity. That is, the host is infective. Repeating it again, HBe antigen. Then within a few weeks, serum alanine, that is the enzymes I have discussed already in that graph. That is the same thing over here. I am exaggerating. Okay. Within a few weeks, the enzymes at the serum alanine and aspartate transaminase rise where the jaundice appears. Now, what happens next? After enzymes appear, after a time, HBe antigen cleared. That is at the peak of illness. See, you can see at the peak of illness, this period is critical illness. The HBe antigen is decreased. Okay, it is cleared out. Whereas the HBs antigen, and as I have told you, HBV DNA is usually persists in the serum for duration of clinical symptoms. So here all the patient presents with that fatigue, jaundice, and all clinical symptoms, and this is cleared with recovery. When the symptoms decrease, then the HBV DNA and the HBs antigen is cleared. Now what happens next? Antibody to the HBC core. So as I have told you, HBC antigen is not detected in the serum. Antibody to HBC antigen appears shortly before onset of the illness. Initially, what I have told you, IgM appears, then it declines, then IgG appears. Okay. Now, antibody to HBe antigen, that is anti-HBe, this one, the green line. Okay, anti-HBe. Oh, anti-HBs, I have not showed you. This is the bold red line. Okay. So initially it is IgM and then later on it becomes IgG. Okay. Now the green line, coming to the green line, it is anti-HBe. What is it? It usually appears after clearance of the anti-HBc. This is cleared. The yellow line, HBe antigen is cleared. From here, anti-HBe antigen, antibody, that is green line appears. Remember, okay? This often occurs at the peak of critical illness. Thus, loss of HBe antigen and appearance of anti-HBe is a favorable serological marker during acute hepatitis B. Okay, have you understood my point? So now what happens? Antibody to HBs antigen arises late during infection. What is that color? The violet color. See, anti-HBs, very far away. This blue line is anti-HBs AG. Very far away, after some 2 or 3 months, it appears, arises late during infection and usually during recovery or after clearance of HBs antigen. So three types, three factors. Then anti-HBs persists after recovery, being the antibody associated with immunity against HBV. So this violet line indicates the marker, okay, antibody associated with immunity. That means when this is there in the serum, it indicates that the host is having immunity towards the virus. Are you understanding? Now, this I have discussed as acute hepatitis. This course offers in acute hepatitis. What is the course in chronic hepatitis? Today my topic is chronic hepatitis. Okay. So, similar pattern, same initial pattern occurs, remember, of serological markers with appearance of HBV DNA, then HBs antigen, then HBe antigen, and then anti-HBc. So, in these persons, however, viral replication persists and what happens in chronic hepatitis? Specific point is viral replication persists and HBs antigen, HBe antigen, and HBV DNA continue to be detectable in serum, often in high titers. So, as I told you, in acute it all disappears. Kada? See, the yellow line indicates HB antigen, it disappears, and then under peak of the anti-HBA antibody. But in chronic, we are saying that these all three will be detected. HBe antigen, HBs antigen, and HBV DNA will be detected in high titers in chronic. So, why? Because, as I told you before, simple. Active replication is going on. The liver is getting damaged. Okay. So, that is the serology. I hope you have understood. You at least draw this diagram and then try to explain in few points. At least draw the diagram and label. It is very highly scoring. When you enter the exam hall and you are given this question and you don't draw this diagram, it is a really blunder mistake. Okay. So, what is the basis for the treatment of chronic hepatitis? So, this graph or this picture shows you how or on what basis you will go for the treatment, that is management. So, chronic hepatitis B has occurred. As I told you before, what all you see? Mainly hepatitis B virus DNA and alanine. I told you now, ALT is more elevated than, alanine is more elevated than aspartame. So, ALT is more important in chronic. Okay, so these two are the main markers or main factors or laboratory diagnostic thing which you see. Okay, so what will happen? If there is HBV DNA and alanine transaminase is elevated, both are elevated and both are detected in serum, definitely you have to go for the treatment. Okay. What about if the HBV DNA and alanine transferase are not there, not detectable? We are thinking it is chronic hepatitis B and these are not detected, there is no requirement of treatment. That is, what does it mean? Chronic hepatitis B is self-resolving. Then, what happens when there is both are detected and or HBV DNA is detected and ALT is not, either of them? You have to go for liver biopsy. Okay? If in liver biopsy, what you see in liver biopsy? What factor is noted? Histological factor is noted. So, according to histopathological features, where it is low or mild disease, then there is no requirement of treatment. When there is histopathologically, there is moderate or severe disease. This is of a grade of histopathological. That will be discussed in cirrhosis and hepatocellular carcinoma. Okay, then the treatment is required. I hope you have understood this picture. This is the basis of treatment. This is, you have to remember lifelong. When you get a patient or your relatives or anyone, you have to remember this. Okay. So that is the graph. So management of chronic hepatitis B is directed. So what is the point? Suppressing the level of virus replication. That is hepatitis B antigen. In addition, restoration of impaired hepatitis B virus specific T cell function has been shown successful suppression of hepatitis B virus replication. That is with antiviral therapy. Now, as of date, there are 7 drugs have been approved for treatment of chronic hepatitis B. That is injectable interferon alpha and pegylated interferon, that is long-acting interferon bound to polyethylene glycol. Oral antigen agents are lamivudine, adifovir digovoxil, entecavir, telbivudine, and tenofovir disoproxil fumarate. You have to remember the names. These are all used nowadays. Okay. The ideal treatment of that is where HBs antigen loss with seroconversion. There, this is the main goal. See, what is the main goal? We have to decrease the viral replication, that is loss of HBs antigen with seroconversion. But this goal is rarely achieved. We have all created drugs still there, discovered drugs still there, but the goal is never achieved. Okay, at least the viral replication is decreased to a certain amount. Therefore, in patients who are HBs antigen positive at baseline, the expected outcome is loss of HBe antigen with anti-E seroconversion and normalization of liver enzymes, obviously. In patients who are HBe antigen negative at baseline, the expected outcome is clearance of HBe DNA and normalization of liver enzymes. Patients who are HBe antigen positive at baseline, treatment should be prolonged at least 6 months after HBe antigen loss or seroconversion. Totally, these patients should be monitored because they might get reactivation. Okay, then it results in chronic liver damage. In patients who are HBe antigen negative at baseline, treatment should be continued indefinitely. Antiviral resistance is a phenomenon observed with the use of nucleoside or nucleotide analogs. These are the drugs which we use. Resistance should be considered in patients where there is lower suppression of achieved pylon therapy. Tenofovir and entecavir have a high genetic barrier for resistance, that is lowest susceptibility when compared to other nucleoside and nucleotide analogs. Okay. So I'll be discussing about the drugs a little bit in detail. First one, this is the main I told you, pegylated interferons or interferons, antiviral. These are antiviral, anti-proliferative, and immunomodulatory effects. Okay. These are interferon alpha, beta, and gamma. Interferon alpha and beta binds to the same receptor and have dominantly antiviral effects. Interferon gamma binds to a separate receptor and has most marked immune regulatory action and less potent antiviral effects. So what pegylation causes? What does pegylation of interferon cause? Reduces the rate of absorption, renal clearance, decreases immunogenicity, and increases the half-life of the drug. Okay. What is the dosage of interferon? Interferon alpha, now interferon alpha is again 2A and 2B. It is given subcutaneously and 10 million units thrice weekly, or 5 million units daily, these both for 4 to 6 months, or PEG interferon alpha 2A, it is given as 180 micrograms weekly, or the PEG interferon 2B is 100 micrograms. 2A is 180, 2B is 100 micrograms weekly for 48 weeks. So what could be the complications of interferon therapy? This includes systemic flu-like symptoms, marrow suppression, emotional debility, irritability, depression, or anxiety, autoimmune reactions, that is autoimmune, especially autoimmune thyroiditis, miscellaneous side effects such as alopecia, rashes, diarrhea, and numbness and tingling of the extremities. With the possible exception of autoimmune thyroiditis, all these side effects are reversible upon you can lower the dosage of the drug or cessation of the therapy. Okay, except for the autoimmune thyroiditis, all these complications can be decreased. Okay. So, what is the first line treatment? Those two drugs, okay, entecavir and tenofovir. Entecavir is nothing but the oral nucleoside, that is guanosine analog. 0.5 milligram orally and 1 milligram orally in case of lamivudine resistance for 48 weeks. Tenofovir, that is oral nucleotide, a cyclic analog, that is 300 milligrams daily. Second line, telbivudine, adifovir, lamivudine. Telbivudine is oral nucleoside thymidine analog, 600 milligrams daily. Adifovir, Oral nucleotide, that is adenosine analog, 10 milligrams orally daily for 48 weeks. Lamivudine oral nucleoside dideoxy 3C thiazide analog, dose is 100 milligrams daily orally for 48 weeks. So this slide, next slide, shows you the treatment recommendations. Okay. I have kept it for as for your knowledge, but no need to remember much. HB antigen reactive, which is divided as HB antigen reactive cases, how you treat HB, and as I told you, only HBV DNA and alanine transaminase are noted. So these are, you always remember that in any case, HBV DNA should be maintained as more than 2 into 10 to the power 3 international units per ml, or alanine transaminase is less than into 2 or into upper limit of normal. ULN means upper limit of normal. Okay. So either in asymptomatic, here this gap is for asymptomatic, then chronic hepatitis, cirrhosis compensated and decompensated. 2 phases are there. In that way you treat. In asymptomatic, this is their values. There no treatment is required. You just monitor the patients. Okay. In chronic hepatitis, you have to treat with oral antigen agents or peginterferon. Chronic cirrhosis compensated form only with oral agents and not peginterferon. Decompensated, you have to consider oral antigen agents and refer for liver transplantation. Okay. So only in chronic hepatitis you consider the pegylated interferon, not in cirrhosis decompensated and decompensated. There is no effect of it. Okay. How do you prevent or prevention? Individuals are most infectious when markers of continuing viral replication, that is HB antigen, or high levels of HBV DNA are present. So where are these HBV DNA? Found in saliva, urine, semen, and vaginal secretion. So you always remember, hepatitis B is more dangerous than HIV. Transmission is more faster and quicker in hepatitis B. Always keep it in mind when you do your house surgery and all. Okay. The virus is about 10 times more infectious than hepatitis C. Which in turn 10 times more than? So here, this point is there. HBV is more complicated than hepatitis C transmission. And then that is more in 10 times more than infectious than HIV. So always keep this in mind. Okay? In surgeries and all, it is very important. You have to be very careful. Recombinant hepatitis B vaccines containing hepatitis B as antigen are available. This produces active immunization in 95% of normal individuals. Infection can also be prevented or minimized by intramuscular injection of hyperimmune serum globulin. Okay? Hyperimmune. Intramuscular injection, remember, hyperimmune. This we all healthcare workers have to get this vaccination. From blood containing anti-HBs, this should be given within 24 hours or at most when you are exposed. Okay? At most a week of exposure to infected blood in circumstances likely to cause infection. Neonates born to hepatitis. What about neonates born to hepatitis B infected mothers? They should be immunized in birth. Okay? They should be given this immunoglobulin. So what is the prognosis? Overall prognosis of patients with chronic hepatitis is directly related to the severity of the disease. How severe the disease is decides the prognosis. Okay, so in patients, I mean for those with chronic hepatitis and cirrhosis, the 5-year survival rate is about 50%, half. Okay, so that is the end of the chronic hepatitis B. Okay. I'll quickly discuss about chronic hepatitis B. Why am I discussing this? Because this doesn't have, so hepatitis B virus is remember, what is a hepatitis B virus? It is a DNA virus, double-stranded DNA virus. Hepatitis B is a RNA defective virus that has no independent existence. So it requires a so-called seroconversion or an attachment, or you call this a saprophyte. Okay. It requires HBV for replication. Reason being RNA. Okay. It can infect individuals simultaneously with HBV or can superinfect those who are already chronic carriers of HBV, hepatitis B virus. Okay. Simultaneous infections give rise to acute hepatitis, but often severe and is limited by recovery from hepatitis B infection. The patient should be recovering from hepatitis B virus infection initially. Then infections in individuals who are chronic carriers of hepatitis B virus can cause acute hepatitis with spontaneous recovery. And occasionally, simultaneous cessation of the chronic hepatitis B virus infection takes place. Chronic infection with hepatitis B virus and HTV can also occur, and this frequently causes rapidly progressive chronic hepatitis and eventually cirrhosis. So, chronic infection can occur as well as acute hepatitis. Acute hepatitis is always limited to recovery of HBV infection. Chronic infection results in progressive. Both viruses are there, so definitely it will result in progressive chronic hepatitis and eventually cirrhosis. Okay. So this is the structure of hepatitis D, or known as delta virus. What is the name of hepatitis B virus? The virion DANE, D-A-N-E. Okay. So what is the structure of here? It is a single-stranded negative sense circular RNA virus with an envelope made of hepatitis B surface antigen. Virions are 35 to 45 nanometers and are roughly spherical, with no distinct nucleocapsid structure. Do you see any nucleocapsid? The hexagon? No. Nucleocapsid is made of 60 large and small delta antigens. These are only proteins encoded by HTV, and HTV relies on host cell machinery. As I told you, it has to have dependence for replication, and the viral genome serves as ribozymes for self-ligation and cleavage. So there are ribosomes, okay? Viral replication occurs in the nucleus of primary hepatocytes. New virions can be assembled only in the presence of hepatitis B virus. Okay? So what is epidemiology and mode of transmission? Hepatitis B virus has a worldwide distribution. It is endemic in parts of Mediterranean basin, Africa, and South America. Transmission is mainly by close personal contact. Okay, similar like hepatitis B. Okay, but not as infectious as hepatitis B. Okay, occasionally vertical transmission occurs from mothers who also carry hepatitis B virus. So that is co-infection. I'll discuss it in the next slide. In non-endemic areas, transmission is mainly a consequence of parental drug abuse or misuse. Pathophysiology, okay, this is important now. Very simple, only two terms are important over here, co-infection and superinfection. As the main point is, HDV virus requires hepatitis B. Hepatitis B virus requires hepatitis B virus for replication. So either it is co, that's I'll just tell you. HDV infection clinically presents as co-infection, that is acute hepatitis B and D. It is acute. As superinfection, chronic hepatitis B with acute hepatitis D. Okay, which may progress to chronic infection and cirrhosis, or remains as latent infection, that is in the liver transplantation setting. So this, what is co-infection? They'll ask you, what is the definition or anything? Co-infection occurs when HDV and HBV are contracted simultaneously, results in acute HDV and HBV infection, co-infections, which are usually acute and self-limiting infection. So, this acute HDV and HBV causes chronic HDV infection in less than 5% of co-infected patients. 5% it results in chronicity. Okay, remember that. What is superinfection? When superinfection, it occurs when HBV B, Bombay, by carriers. So I told you the latent, that graph you remember, hepatitis B latent, those are carriers, are infected with HBV B. Okay, leads to acute hepatitis and chronic hepatitis B infection. Acute hepatitis B and chronic hepatitis D infection in 80% of cases. Superinfection is associated with fulminant form of viral hepatitis. What is fulminant viral hepatitis? This is important. It is the most severe form of acute disease, which is about 10 times more common in hepatitis B virus infections than other types. Hepatitis B, fulminant. Hepatitis B. Remember that. Delhi. Okay. Characterized by hepatic encephalopathy and the mortality rate is 80%. So fulminant viral hepatitis is very dangerous. Okay. That's why it is important. Chronic hepatitis D progresses to liver cirrhosis in 60 to 70% of patients. Okay. So as I told you, this graph shows about the superinfection, that is typical serological course. Okay. And this is the time of exposure, and over here same course like hepatitis B. Okay. So the hepatitis B as antigen is chronicity. See, throughout you can see. So this will be the carriers. Superinfection mane, it should be the carriers where the hepatitis D infects and HTV RNA. This is the clinical phase. The jaundice and symptoms are here. This is the non-clinical phase. And as HTV RNA decreases, alanine transaminase is normal or mildly elevated, and anti-HTV is always elevated. See, always. And anti-HTV IgM is decreased. First, initially in clinical phase, it's increased, and then it is decreased. Similar course is seen in co-infection. Co-infection alanine transaminase is also elevated. What is the clinical presentation of HDV via chronic hepatitis B? Patients with co-infection, the course is transient and self-limited, whereas rate of progression to chronic is similar to one reported for acute hepatitis B, as I discussed before. Superinfection hepatitis B virus carriers may present with a severe acute hepatitis exacerbation with frequent progression to chronic HDV, severe acute hepatitis exacerbation. So how do you diagnose HDV RNA or HDV antigen in serum or liver? Detection of antibody to the HDV antigen in the setting of acute or chronic hepatitis B virus. So see, this is the picture you can easily remember. Detection of IgM and IgG antibodies to antigens. Ultrasound. Ultrasound, what you see? Liver pathology. Okay. Liver function test. That is the enzymes. Determination of virus RNA and MRI. If ultrasound requires further investigation, then you go for MRI. PCR, polymerase chain reaction. What is it known as? Polymerase chain reaction name is known as TACMAN. TAQMAN. TACMAN. This is question will be asked in PG bit. Then complete blood count and biochemical blood. These are the routine tests. Okay. So what is the basis of treatment here? When there is a hepatitis B antigen already infected individual has the detected anti-HPV IgG antibodies detected. If it is negative, treat according to hepatitis B virus guidelines. You treat for only hepatitis B. If there is associated anti-HTV IgG antibody, you go for the test of HTV RNA. If it is negative, there is no HTV RNA, you repeat HTV RNA after 3 to 6 months. Then consider HTV IgM. Okay. See, understood? First, initially HBS antigen you get anti-HTV IgG antibody you do. Then you detect HTV RNA. If it is negative, you repeat this after 3 to 6 months. And next time what you consider? I consider HTV IgM. Then if HTV, this is the case of if HTV RNA is negative. What if it turns out positive? So you have IgG antibody, HTV RNA positive. Then you pakka go for consider PEG interferon alpha treatment for at least 48 weeks. Dosage I have told you before. Now, if HBV more than DNA, more than 2000 international units per ml, consider combination treatment with nucleotide analogs, nucleoside or nucleotide analog. Okay. So, if there is no HBS antigen decline, no HDV RNA decline after 45 weeks, you have to stop the therapy. This is after you give PEG interferon alpha. Then, if there is no HBS antigen decline and HDV RNA has turned out negative, then also you can stop the therapy. Okay. But if there is continued hepatitis B as antigen decline, irrespective of HTV RNA. So, main point here important is HBS antigen. Okay. HTV RNA, you give the symptomatic treatment treatment. But HBs antigen should be cleared out. Remember that. It's after 48 weeks. Continue PEG interferon alpha until HBs AG there is loss. Okay. Treatment. Interferon alpha, as I told you. And how do you prevent? Although there is no vaccine to prevent HTV carriers with HPV, both infections can be prevented by timely administration of the hepatitis B virus vaccination, as I have discussed. Thank you. So please read hepatitis B, both acutes discussed in the previous class as well as now chronic. This is a very important topic. Hepatitis B should be thorough, both clinically and practically, and theoretically and practically. Okay, that graph is very important. Serological markers, if you draw it, it is highly scored. Okay, very important question in your final exams. Okay, thank you.